Michael Janssen and the Center for Spine and Orthopedics in Thornton, Colorado. They have a very pertinent topic that is frequently overlooked, and that is disc herniations, and a number of great articles. And we thank all of you who are online with us, and we're looking forward to a great review of this common topic and pertinent discussion. So, Mike, good morning from Seattle. How are things in Colorado?
Everything is great. We've only had one major snow, but everything is stable. Okay, so thank you very much. I think I have control of the slides. We chose to do something which is really the most common thing that most of us that deal in spine care, either non-operative or operative, to take care of, which is lumbar disc herniations. And even though it's the most common thing that we take care of as clinicians, and I think that there's, to really take a few minutes and review some of the pertinent literature of what we've found and what we make decisions on, I think will hopefully open up some really good discussion overall. Okay, how do I get this command to the slides here? They're not advancing for me. Did I do something wrong?
You should have access now. You just need to click anywhere in the.
There we go. Whoop, I'm gonna go back one. So the first article I wanted to kind of take a look at is the one from the NIH Public Access, and it's really the surgical versus non-operative treatment for lumbar disc herniations, and it's really referred to as a sport trial. I've seen this show up on the recertifications of the boards and some of the key literature and what this really is showing us. I remember when this was presented at NASS, and we all had these great ideas of how this was going to influence us as clinicians and what we can learn about. Many of the people that may be listening or some of the attendings on may have participated in this particular clinical trial. But really there were two that were initially published. The first was in '06 in both JAMA, two sets. One was the observational cohort you see on the right, which was surgical versus non-operative treatment. And the right side was the surgical versus non-operative treatment for the patients in the randomized trial. But then combined with this manuscript, which was published 2 years later in 2008, which is the one we're going to discuss, combined both the randomized trial and the cohort trial. The statistics are somewhat very difficult, and they take quite a while to kind of go through. I remember when this was presented at NASS, and it was somewhat difficult to follow, but we'll just try to make it somewhat simple. The purpose of this study was to look at the 4-year outcome of, again, one of the most common things that we see, which is lumbar disc herniations, and what is the real benefit of surgery versus observational care. We all know from our community that there's a huge different philosophies on how these are managed, number one. Number two, not all disc herniations are the same. We all know that a small posterior lateral disc may be different than a large central disc versus an extruded fragment, but we all lump them together. And they're treated different from our pain management physicians to chiropractic physicians to occupational medicine to surgeons. And so we have a whole portfolio of different ways that we think to manage them. This study went over 13 centers from 2000 to 2004. And there were two different designs, the observational, which had a little over 700 patients, and the randomized, which had just slightly over 500 patients in it. To be eligible for this, the patients had to have symptoms consistent with the radiculopathy, 6 weeks of symptoms, clearly that their clinical signs and symptoms had to match the imaging, and to make a decision whether they were a surgical candidate. And then the patients were offered to be enrolled in either the randomized arm or the observational cohort. The surgical treatment would be a standard microdiscectomy involving the root and removing the offending pathology. The non-operative protocols included physical therapy, education, exercise, time, and anti-inflammatories. Even though today in 2020, most patients that I see have epidural steroids, selective nerve root blocks, EMGs, and a whole gamut of technologies that wasn't really part of it at this particular time in the non-operative. The patients had to have follow-ups for 6 weeks, then 3 months, 6 months, and then on an annual basis. And probably the interesting thing we'll ask at the end of this is, what does most of us follow our patients? And many people don't follow patients that have a microdisc or a disc herniation unless they're recurrent beyond that of 3 to 6 months anyway. But the endpoints are listed right here, which are fairly standard, the SF-36, the Oswestry. I'm not used to using the bodily pain and the physical function scales. And then secondary improvements, which was whether they returned to work, whether they had a severity of their symptoms, and what the status was. So the overall results is there was a little over 1,200 patients involved from lumbar disc herniations, 500 in the randomized, 700 in the observational. The key is the treatment arms. 245 of them were assigned to surgery and 256 were assigned to non-operative management in the randomized portion. The key is in the surgical arm, which is somewhat confusing, just less than 60% had surgery at 1 or 4 years. The non-operative, there was a big crossover because a little over 40% to 41 to 45 ended up having surgery at either 1 year or 4 years, even though they were placed in it. So we had a huge crossover, which I think made it difficult when this was initially presented to understand. In the observational cohort of the different group, there were 500 patients that chose surgery, 222 went to non-operative care, and of the surgical arm, 95% had surgery at a year, none of them beyond that, or beyond 4 years. The non-operative arm is the crossover key. 20% received surgery at a year, 24% by 4 years, and 35% is the only remain non-operative. So of all the patients that went into the non-operative arm, only 35% of them maintained non-operative. So the results of this, when you try to break it down, the overall follow-up was really quite high. I mean, this is what we've seen in some of the clinical trials with non-fusion technology and other FDA studies. It was 96% follow-up, 94 in the randomized, and 97 in the cohort, which is quite substantial. I think it's interesting to look at the complications. They didn't really describe this, but 6 patients had blood transfusions intraoperatively. So this must be, I assume, this thing that we always worry about if someone putting a pituitary too far into the disc space and causing a vascular, but it didn't really go on and dissect those 6 patients out. There were no perioperative mortalities. Dural tears was about 3%. That's probably what most of us tend to discuss with patients unless it's recurrent. But the reoperations, I think, is the key. About 50% of the patients that had a reoperation were ultimately recurrence. 6% of them at a year, 8% at 2 years, 10% at 4. So over time, clearly the reoperation rate went up to about 10%. Complications. When you take a look at this, was 2014 study looking back now for 8 years, the reoperation rates. 85% of those patients at 8 years that had a reoperation rate were due to a reherniation. And you can see how that increased over time from 11% up to 15%, which is always what patients ask us all the time. We've tried, a lot of us, to have different ways to close the annulus and do a variety of things. And I think in spine, in my career in the last 2.5 decades, it's one of the things we don't have great technology on once we remove a disc, is to figure out how to manage this and can we decrease the incidence of recurrence. Crossover. The patients crossing over from non-operative care to non-operative care was about 20%. The patients that were scheduled to have surgery or in that group that crossed over to non-operative care tend to be those that had higher financial incomes, maybe a little less pain and disability, less likely to have ipsilateral straight leg raising, more likely to have a higher level disc herniation, L3-4 and 2-3, and those patients that were less dissatisfied with their symptoms, meaning it was more of an annoyance probably than an impairment. On the other hand, the patients that crossed over to surgery, which was 25%, were lower income, had worse physical functions. They were more self-related disability, more dissatisfied with their symptoms. They're the patients that come in and say, Dr. Ken, I'm just not getting better. They were perceived that they were getting worse, and they expressed a baseline preference like, I want surgery. So the treatment effects. So what happened here? The intent to treatment, or the randomized cohort, all measures over 4 years tended to favor surgery. There was no statistical significance, though, in the primary outcomes. The secondary outcomes, on the other hand, were statistically significant, was for the sciatica, that was bothersome index, and the self-related improvements. The as-treated group, the treatment effects for the primary outcomes were significant at 2 years, and they tended to maintain themselves at 4 years. They were significantly favored for surgery in all outcomes but one. And the work status showed there was no significant benefit of surgery at 4 years. So that kind of gives us an overview of what we probably have from the largest database, I think, in lumbar disc herniations, of looking at those that were placed into non-operative care, those that were placed into surgical care, and the crossover rate. And now I think if we can open this up for a few minutes of discussion before we discuss the rest of them, because we got a few minutes. Jack, Rich, anyone have any thoughts on how this study, if anything, changes the way you manage patients or educate patients upon the outcome of managing a patient with a disc problem?
I think he pointed out, this is Scott Blumenthal, I think he pointed out the weaknesses in the study. Probably the most pertinent of which would be a herniated disc is not a herniated disc is not a herniated disc. It's a heterogeneous population. And, to my mind, they've gotten a lot of publications, presentations, but this was a big waste of government money. I don't know that we learned anything from this.
I think the statistics at best were confusing. And I don't know that anybody took a solid message away from this. I think as surgeons, we all felt that this pointed the benefits of surgery for our patients, which I think we recommend to them anyway. But I just don't know that anyone could really solidly say this study proved a certain point. So, as Scott said, several publications came out of this in prestigious journals, but to nobody's real benefit.
Well, it helped me understand from a statistical and analytic standpoint of looking at papers. I didn't really have a good grasp on, intent to treat and as treated. And, I think that's kind of brought into the forefront and crossover to drug studies as well. I mean, if the conclusions are based on the original randomization intent to treat, and you've got a 40% crossover, you're not getting any clinical information on that.
I mean, for me, this is the single biggest take-home message, and that is that surgical randomized controlled trials in which the control arm does not offer a certain zing, a certain really meaningful intervention in the patient's eyes, at least, are doomed to fail in our country, at least, in our culture. The second thing is that it is so hard, having done like you guys and like Mike, prospective clinical trials, when you look at the big data at the end, it is so hard to try to make sense of what the various sub-motivations of patients were. Workman's comp here, family on vacation there, stuff like that. Trying to cram that into a larger statistical picture is near impossible. The big picture for me is very clear, and it was surprising because this is not necessarily a surgeon-friendly group that was pioneering this. And this is that surgery is actually better. So despite these horrendous and unovercomable limitations that were game-changing, by the way, in terms of how PRCTs are viewed for surgical trials, this was actually a very pro-surgery thing. And if you wait too long, that'll have adverse effects on the patient's well-being. Thanks.
Any idea how much the study cost to run? Does anyone have any idea? I couldn't find it in the
study. I know because we were supposed to participate in it. The budget was $3.5 million for the initial sport trial. They did get additional grants, and I don't have a handle on that for the longer-term follow-ups.
Any other comments before we discuss a little bit more of some other lumbar disc considerations? Okay. Clay.
All right, I think I have control of everything now. My name is Clay Dornkamp. I'm the Orthopedic Spine Fellow at the Center for Spine and Orthopedics. I appreciate the opportunity to talk to you guys today. One of the two articles that I'm going to discuss actually came out of the Global Spine Journal, and looking at the radiologic predictors from MRIs, looking at microscopic lumbar discectomy after lumbar disc herniation. This was published in 2019, and there we go. The purpose of this study was to investigate the radiological differences, specifically in MRIs and lumbar disc herniations between patients receiving microscopic lumbar discectomy and non-operative management. So a little bit of background for this: microscopic lumbar discectomy or microdiscectomy has been shown as to be a cost-effective method of providing immediate and long-term relief for patients. I think this is an important study because we have shown that non-operative management can be successful in a subset of patients, but it's important to differentiate which patients do well with surgery versus who don't. And because of some of the variations in the literature, it's good to see what factors lead to a favorable surgical outcome. And this study aims to help surgeons identify radiographic disc morphologies that predict need for surgical management. So this was a retrospective review of consecutive patients at a single academic institution between 2012 and 2017. They looked at patients who had symptoms, as well as consistent examination and imaging with a herniated disc. And it was broken into two groups, one which was a microdiscectomy group and the other a non-operative group. So the indications for surgery was based on a shared decision-making model between the physician and the patient. And they looked at the presence and durations of symptoms. They had to have failed conservative treatment for more than 6 weeks. And then they had a presence of a progressive, or if they had a presence of a progressive neurologic decline. They excluded patients from the study if this was a recurrent herniation that had a previous microdiscectomy, or if they had a surgical treatment other than a microdiscectomy, such as a lumbar fusion. So the things that they looked at for MRIs, they based their findings on the T2 weighted MRI. They used the Carnegie et al. Study from 1997 to look at disc and canal measurements. They looked at cephalad and caudal migration of the disc and disc hydration, whether it was black, gray, or mixed. So this was showing how they calculated some of their findings. The image on the left side of the screen is the method from the Carnegie study, looking at the area of the disc and the area of the canal. And the thing on the right was the imaging looking at the cephalad and caudal migration. So, and this just breaks down the demographics. I'm going to go ahead and go to the next slide where I have the same image. Really, if you look at the age, gender, and BMI, they were all fairly consistent with no statistical differences between those. If you looked at the herniated disc area, they noted that the larger the disc, the more significant, or it became statistically significant that they underwent surgery. Also, the migration of the disc had statistical significance, as well as the magnitude of migration. And then a gray disc was found to be statistically significant for predicting need for surgery as well. Overall, there were 16 surgeons involved in this with 285 patients. So what they ended up finding was that patients receiving surgery in the microdiscectomy group had significantly larger axial herniations. They had caudal migration, larger canal migration magnitude, gray disc signal, lower frequency of black discs. And when they broke these out, the factors that showed the strongest predictor of patients ending up going under surgery were having a gray disc signal. And they found that they were over 5 times more likely to receive surgery. If the herniated area was greater than 70.52 millimeters, they were twice as likely to have surgery. The canal compromise was greater than or equal to 20%. They were 3 times more likely to undergo surgery. If they had caudal migration, they were 6 times as likely to undergo surgery. This was their decision tree analysis, which shows that, again,
How big is it?
gray disc signal had a predictive about 67% of those patients underwent surgery, and up to 75% if they had a gray disc plus a herniated area of greater than 70.52 millimeters. And then the magnitude of migration, 40.5% of those patients, 6.8 underwent microdiscectomy, and so on. So I think this study does a good job of showing, especially for me as in the early stages of my career, helping me look at MRIs and determining which ones I think patients would do poorly with a non-operative arm. However, this study does have the limitation that they strictly looked at patients that had surgery or who didn't have surgery. They didn't look at their clinical outcomes after surgery. So I think they missed capturing a key aspect of the clinical presentation. And in conclusion, I think it does reaffirm the conclusions by the Carnegie et al. Study in '97 that MRI morphogenic features can be strong predictors of undergoing surgery and possibly predict outcomes. However, this study didn't look at the outcomes of the surgery, and these can be used to help educate our patients when discussing the surgical options in the clinic.
Hey, Clay, the issue I have with this is it's purely a radiographic phenomenon, and I hope nobody listening to this ever operates on x-rays without examining a patient first. And I can't tell you how many times in my career I've walked towards a new patient exam room and you see the MRI hanging up and it shows a big disc, and you kind of start to salivate, and you walk in the room and the patient's neurologically normal and their pain is resolving, and you're not going to operate on them. So yeah, there's an issue here with just identifying radiographic factors and thinking that that's going to tell you which patient to operate. And then, as you said, it didn't follow outcomes. So you don't even know that it's the appropriate outcome, even if you do operate like a Pavlovian dog, just based on the x-ray findings. But it was a good review. Thank you.
I think that was a great point, Jack. But let me ask you a question, Jack. How often do you guys see patients that have a disc herniation, and by the time they show up to you, even if it's an extruded fragment, they've had 3 epidurals and an EMG, and do any of those things alter the natural history, or would that patient been better just to have this fixed from the beginning?
Well, months have already gone by, so if they're better, Mike. The question is whether you see somebody with a big, juicy disc herniation very early in the course, whether he'd be better off. And, Scott Blumenthal will often pass by and look at an MRI I'm looking at, and he'll say, I hope you're not going to waste any steroid on that. Because I think most surgeons have that feeling that if you have somebody who's really badly off early in their course with a big disc, that their course is going to be better with a surgical intervention than with prolonged conservative care. And then if they don't get better, having surgery, which is probably not going to have as good a benefit.
I think Mike's point is very well taken, that there's no study that suggests that any of that alters the natural history. And if it's going to get better in 6 weeks, it's going to get better in 6 weeks, whether you inject it with steroids or not. They might feel a little bit better along the path. We all send our patients to physical therapy as well. I don't think there's, anything altering about physical therapy.
And Mike, just to reiterate, what Jack and Scott said, basically, we see many patients that you see with the hernia disc, and somehow they got better, and you don't see them for a couple of years. They come back and they have recurrent pain, and oftentimes you see that the regional disc herniation has totally resorbed. So that's why Jack's point about treating patients is so important. We don't treat the x-rays, and unfortunately today we see it too often, especially in our area where we have too many spine surgeons. Basically, they look at the x-rays, walk in the room and say, you need surgery. And while what Scott said is appropriate, we don't know that steroids really modulate the course of a hernia disc. They don't cure people. What we're trying to do is keep them comfortable. Going back to what Jack said, or maybe Scott said, 6 weeks. In other words, if they're miserable, and if you can get them through the first 6 weeks, they feel better, then a lot of those patients would do well. But if they don't get better, obviously surgery is going to be the answer. So that's why a study like this, I think, is a bad study, because it sets a bad example for the young surgeons out there saying, oh, well, yes, because it's this kind of disc, I need to operate. It reminds me years ago when, we first started TBI, I would see patients that came to me for a second opinion. And the story was 3 days of pain, and they saw somebody else and they needed to have immediate surgery. And I'd say, well, wait a minute, let's see if we can cool things down, and then we can make a decision when a little bit of time has passed. And nobody wants to make a patient tortured. You're going to do surgery eventually if they need it.
So this is
quick question. Do you think that EMGs offer any value in helping to decide which of these patients need surgery?
0.
I disagree totally.
Really?
Yes, they are very helpful in terms of identifying and differentiating patients with comorbidities, i.e. diabetes. And I know we're talking about the lower back now, not the neck, where it's even more relevant. For instance, for brachial plexopathies, compressive neuropathies, etc. But it also helps prognosticate. But you need to have a good examiner and somebody who's knowing what's going on. But it's very helpful to differentiate neuropathy, and in terms of acute versus chronic radiculopathies, identify likelihood of residual neurologic changes. So while it's not anything in terms of an acute disc herniation in a healthy young person, I agree with that. It does help guide prognostication and disclosures to the patient.
So Jens, do you get them on many patients? Because I think I rarely do it, and I like to hear what Jack and Scott say as well, or Mike.
So since you asked me, I'll just go first, but I'd be curious to hear other opinions also. So we have a lot of patients who come with confounding factors, repeat surgeries, recurrent herniations, insufficient relief after initial decompression attempts, especially with endoscopy or stuff like that. And comorbidities. I mean, I keep coming back to that. People with all sorts of stuff going on and complex neurologic symptoms. And it absolutely helps my clinical practice. And I think the rehab literature does identify it also, to identify that. Now, these are factors that basically look at neurophysiology, reinnervation versus chronic denervation, axonal loss. And again, that is undisputably a help in trying to counsel these patients who have ongoing questions. So
Jens, I don't disagree with you, but I think for the fresh herniation, which is what I was making my response to, I don't think it's helpful. But yes, when you get all the comorbidities, obviously you want to do everything you can to make a diagnosis and have some prognostication as well.
So there we have agreement. If you narrow it down to
yes, I agree with what you said, Jens.
Okay, great. Any other comments on this? And then Clay, are you going to finish up on the next one, and then we'll move on?
No, I'm gonna go.
Okay,
so,
Jake.
Yep. All right. So I thought I would talk about an article that a lot of people probably may have skipped over, which came from our Asian colleagues, the Asian Spine Journal, and this was recently published in 2019, and it's factors affecting early and 1-year motor recovery following microdiscectomy in patients with lumbar disc herniation. And unlike the last paper, this one is really looking at what factors motor recovery after surgery, like what influences that. So the purpose, they wanted to see what about the patients can help determine preoperatively who's going to get a neurologic recovery. And it hasn't been said yet in this journal club, and I think it's important to say we're not talking about cauda equina with these disc herniations. Everybody's generally spine surgeons here, so it shouldn't have to be said, but I think we should say that in full disclosure. So this really comes from the fact that there's not a lot of great literature. We're talking about, what do we do? Who's the patient we choose? Who do we offer? Sport trial really gave us nothing to decide. Who do we operate on? There's been a lot of studies that look at, what factors help us predict who's going to have a good motor recovery. So it's been, we've looked at duration and severity. That was determined to be important. Younger patients were thought to have better recovery. More canal compromise was thought to have better recovery. But, there's also articles that look and say nothing helps us predict better motor recovery. So in this paper, they did a prospective longitudinal study of 70 patients, and all of them had a microdiscectomy. All these patients had a grade 3 or less motor exam, and some of them did have bowel and bladder symptoms, which is kind of interesting. They excluded patients with tandem stenosis, that could be myelopathy or thoracic disc herniation causing these symptoms. And they did not include patients with just sensory deficits, which I think a lot of us would not be quick to operate on anyways. So for their patients, they did a preoperative exam and a postoperative at 2, 6, and 12 months afterwards. They asked the patients to recall how long that they'd had their symptoms since their initial onset. And this required patients say how long they'd had motor symptoms. So just isolated back pain did not contribute to what they considered previous symptoms. Then they classified these into an acute onset of patients with less than 3 months, chronic onset, meaning they've had the symptoms for more than 3 months, or an acute on chronic where they had previous symptoms, had complete resolution, and had a new onset of symptoms. Then they recorded the number of total previous symptomatic episodes and other patient demographics. They performed radiologic assessment on all these patients' imaging. They looked at the number of disc herniation levels, at what level it happened at, what the herniation looked like, if there's migration, and the percentage of canal compromised and bony dimensions for congenital stenosis and things like that. They then performed a microdiscectomy, and they defined a significant motor recovery as the patient improving to a grade 4 strength, which, as we all know, is a gigantic grade where it's just stronger than gravity and not full strength. So they use the standard grade 4, not 4-4+ that some will use. So of their 75 patients, 65 of them, or 92%, were available for follow-up, which is actually phenomenal. Of those that had a complete recovery, 63% of those had a complete recovery at, a meaningful recovery, meaning 4 out of 5 at 2 months, but they only had 4 more that had a motor recovery from 2 months to 6 months, and no patients recovered after that 6 months. So, and this is a breakdown of the chart. It's actually a little hard to understand, and I certainly may have drawn this a little differently, but as you see, there's 70 patients. Then each of those that follow along the top are those who did not have motor recovery. So as you can see, this kind of breaks it down visually to show that initially they had a fair amount of good motor recovery. 41 patients recovered within 2 months, then only 4 more patients by the 6-month follow-up, then no more at the 12-month follow-up. When looking at the characteristics of those patients who had a motor recovery, those who had a significant comorbidity or those who had diabetes were less likely to have a good recovery from this follow-up. Looking at those who had cauda equina, which I'm glad they broke that down, those with bladder deficits, 17 of the 65 patients were noted to have recovery. And they didn't specifically say how long each of these patients had symptoms, because I think most of us will agree within 24 hours, at longest 72 hours, you certainly would want to get to a patient with cauda equina syndrome. But some of these were certainly outside of that, and 47% of their patients had a motor recovery if they had cauda equina. There was no association between decreased rectal tone and reflexes with return of symptoms, but that may be also associated with their delay in treatment, which I'm not saying they electively delayed. These patients presented with more than 3 days out. For the assessment of their radiologic findings, they saw that a single level disc herniation had a much better motor recovery rate than multi-level disc herniations, where 75% of those with a single level disc herniation had a improvement, whereas if they had multiple level disc herniations, then only 29% had improvement. But once they took this through binary logistical regression and considered other comorbidities, this was found to no longer be statistically significant. So they evaluated the things that will help us determine if the patient will have good motor recovery. Those who recovered were not diabetic. They had a shorter time interval between the time of herniation or symptoms and decompression. They had less than 2 previous symptomatic episodes, and a symptomatic episode was considered pain in a radicular pattern or weakness. Those who had incomplete motor deficits had better recovery, and those with incomplete sensory loss had better recovery. If the patient had reflexes present and less than 2 disc herniation levels were found to have better recovery. This all makes sense because these are generally patients who had less symptoms and they didn't have a controlled non-operative arm. So these are patients who may have had recovery with or without surgery. Then performing multivariate analysis, the only risk factors were found to be diabetes mellitus and completeness of the initial motor deficit. So the limitations, I think I brought up a couple initially, but I'd say the biggest one is that the study's underpowered and it relies on recall bias of time of symptoms. So I think that in doing that, you really don't know how long it's going to take for a patient to say, oh, it started 2 months ago. And I think that's very commonly unreliable. A motor grade recovery of 4 out of 5 is a very wide motor grade. And I think that this is one of the problems with a lot of our disc herniation literature, is that we don't really have a way that we're grading motor recovery after a disc herniation. So a patient who has a heavy occupation labor trade that has 4 out of 5 strength to their quadriceps or gastroc may be significantly limited, whereas you know, if they have closer to a 5, a 4 plus, they may do better. So, you know, it's one of those, it's hard, and I don't think that our spinal outcome scores really capture that as well as we'd like. Those with acute motor loss of less than 3 months, that's also a wide grade of symptom onset. So if a patient gets to the OR within 6 weeks, are they going to do better than if they're at, you know, 2 months and 28 days? And this obviously doesn't capture that. And lastly, it does not take into account the patients may have had less than full strength before the onset of radiculopathy, because again, it's relying on recall bias. So what I took from the study is that if they have a complete initial deficit, it's probably a poor prognostic indicator for the recovery. And as Dr. Chapman was talking about earlier, patients with diabetes have already an initial insult on their nerves, and their ability to recover physiologically is decreased. So any patient with diabetes mellitus, I'm probably more likely to say that you'll have some weakness after surgery. So thank you, and I look forward to hearing some discussion on this one.
First of all, thanks, Jake, because I wouldn't have picked this up because I normally don't read the Asian Spine Journal, but I found it very, very useful. Do you think that did anything in this article talk about whether the L5 route had a less chance of recovering than compressive pathology at other routes for any reason?
I know they just looked at you know single level versus multi-level.
Sure.
So yeah.
So
we all know that that's a very fickle nerve route.
You know, Jacob, your comment about the grade 4 is such an appropriate one. And I'm amazed that somebody has not come up with some way to do it. And I was thinking, as you were saying that, it's too bad that we can't measure the normal strength and then the affected leg and come up with an objective number saying that it's 85% of whatever. And no one's ever done it. When I was first around practice, it always bothered me. So I had some type of little pressure sensor that they use for the hands. And I tried to adapt it for like the tibialis anterior, but never anything came of it. And it's too bad we don't do it. We're so sophisticated in so many other ways, but yet, as you said, the grade 4 is basically, that's your functional range of motion. You know, worse than that, you're horrible. 5, you're perfectly normal. And we're never going to be able to make any headway until we have some objective measures. Maybe that's a good project for you or some of the younger docs.
So actually that thought is kind of what spurred this journal club on. And I think that our sports colleagues are, far ahead of us. And that's the world I came from before doing spine is, after ACLs and these things like that, they use Cybex machines to compare to the normal side. And I think that's probably possible now. And I think that, multi-center thing with the legends of spine to include Seattle Spines and Texas Back could be very helpful in trying to figure these things out.
It's interesting that, obviously it's a study from India, but, in US, the majority of our patients that we operate on for herniated discs don't have significant motor deficits. But the question I have, does anybody know any good literature? It comes back to timing. If someone has an L4-5 disc herniation, has a foot drop, the standard of care, I don't know if there's standard care. Some surgeons will say that's an emergency. We need to operate on you today or tomorrow. Some, I think most of us realize it's a peripheral nerve and has a potential to recover non-surgically. But is there an over/under to say, look, if you've got a 3 of 5 motor deficit and it's not better by X number of weeks of non-operative treatment, the prognosis goes down if you don't do the surgery? Is there an over/under that anybody knows about?
So I think it's interesting that we know that at least in cauda equina literature, which is a motor deficit, and that's what we worry about is a motor deficit of cauda equina. If you wait more than 24 hours, then you're likely going to have less recovery, and certainly outside of 3 days. So the question is maybe, are we just looking at the completely wrong time points? And is 6 weeks just way too far out? And I don't have a great answer to that. And I think the hard thing is we have so many studies that show that patients actually do pretty well because we're not talking about bowel and bladder. We're talking about maybe requiring an AFO the rest of their life. So, I think that we may always have a hard time with that time point.
I want to make a comment. Mark Dukatowski posted a note here that said for our faculty that the Mayo Neurology Department used its own grading system that they felt was more reliable and more repeatable. 0 being normal strength -1 is -25, -2 is -50, and -3 is -75, rather than against gravity and against some resistance. Does anyone else use that evaluation?
Well, Mike, that's pretty subjective too. I mean, can you tell the difference between 25 and 45 or 45 and 65? I mean, I don't think so.
Yeah.
But to Jacob's point, and I have a question to Jacob, we have biometrics now that test, for instance, dorsiflexion weakness. And again, the L5 root seems to be far more fickle for reasons that we don't fully understand, whether it's myelin thickness or redundancy of motor neurons. I don't know. We don't know. It's certainly more fickle than S1. Jacob, in your review of that article, and I thank you for bringing that up because I did not see that in my ongoing literature review, is there a difference between painless weakness and painful weakness? Because I'm neurophysiologically, I'm always far more worried about painless weakness patients.
So certainly I worry also about a painless weakness patient is that they have likely had an infarct to their nerve root. But in the article specifically, no, that is not something I remember seeing discussed. Yeah.
But we have motor measurement tools now. It's not Cybex, but we are working with a neurorobotics company. They do now have a dorsiflexion recruitment device that is basically a non-invasive surface EMG lead activated, and so they can actually measure that. We actually just got off a conference call with them and hope to be able to look at that because this is a big deal. The recall bias is a very substantial aspect that these authors struggled with, by the way, like all the cauda equina people, and it's still not clear whether it's 24 hours or 48 hours or what the time frame for cauda equina is. Anecdotally, I'm going to ask my partner Amir, who's right next to me here, socially distanced 6 feet. He just operated on one of those typical cauda equina patients. And again, the recall bias and trying to identify time point X and who does what, when, where, how is exemplified by this. Amir.
Hey, thank you for the for the question. Yeah, and I think one of the big problems is if these patients come in through the emergency department, it's very easy with a cauda equina picture as a spine surgeon to kind of quickly move that patient forward. This patient came through my clinic 2 weeks out, and I think all of us, if they have, bowel and bladder issues, that saddle anesthesia and weakness, I wasn't very confident this patient had a 0 out of 5 tibialis anterior. That we all know that's not going to do well. And the problem is trying to get the education out into the community where if this person shows up into your primary care clinic, they need to go to the emergency department. And I think this patient probably could have been saved a serious amount of disability if he would have been pushed that direction rather than sent for an outpatient MRI.
So well said. I think the clinical reality for us, at least here in Seattle, I don't know how it's in Texas and Colorado, and the many cities that are online right now. So great topic is we see so many weird cauda equinoid things. The sensitivity is way too high. The amount of diarrhea from whatever irritable bowel syndrome or constipation is near sheer endless, or BPH problems is endless. And the actual cauda equina patients aren't usually severe acute cauda equina that's just clear. They're kind of these fringe, partial cauda equinoid symptoms that are lingered on and then much delayed with much chagrin afterwards. So the 24 to 48 hour timeline is really wrong. Neurophysiologically, our nerve cells die off or start dying off at around 8 hours, 6 to 8 hours. That's the ischemia time. So that's harsh, and obviously none of us are prepared to or can realistically take patients to the OR that fast, but we really have to do a lot of work in trying to educate patients and the medical community at large towards what are real symptoms for which we should strike faster. So thanks for bringing this topic up.
Great. We've already now discussed the overall sport trial. We looked at MRI, and does that really predict anything, as well as the functional motor recovery. Now, the next article, I think, is to really just take a look at, do these patients return to sports or activities, and should that impact our decisions? Clay?
Thank you. Let me take over control of the slides here. So the next article I'd like to discuss is out of the British Journal of Sports Medicine, and it's the return to sport after open and microdiscectomy surgery versus conservative treatment for lumbar disc herniation. This was a systematic review with a meta-analysis out of a center, academic center in New York, and it was published in 2016. So there we go. And the purpose of this study was to perform a systematic review to determine the return to sport for athletes undergoing lumbar microdiscectomy versus conservative intervention. So they did note that lumbar disc herniation does have a high prevalence of patients that have back pain and radiculopathy in the athletic population. And overall, there's a lack of strong evidence regarding the management of lumbar disc herniation in athletes, especially elite athletes. They followed the PRISMA guidelines, and they queried multiple databases to get their data, including Medline, PubMed, Ovid, and several others. There were 2 independent reviewers in this study, and they included articles that had full text studies in the English language. They included retrospective studies as well as prospective studies. They included professional as well as amateur athletes with lumbar disc herniations. They looked at return to sport criteria and rate of return to sport. They excluded articles that investigated other types of surgery, such as lumbar fusion, articles that were non-English articles, and articles that lacked return to sport information. The interventions that were included in the study, the majority included were microdiscectomy or open discectomy, but there were 1 or 2 studies that talked about percutaneous discectomy as well as percutaneous nucleotomy. When they broke down the quality and the different studies, they used the Downs and Blacks scale to assess the quality of the studies. And when they used the PRISMA guidelines, they found 14 studies that met their inclusion criteria. One big limitation for the studies is that all of the level of evidence in all the studies was either a 3B or 4. 5 studies were graded as moderate quality, where 9 were graded as lower quality. So overall, they had 964 athletes that were studied with low back pain and lumbar disc herniation. Surgery performed was an open and microdiscectomy. Ages ranged, had a very broad age range from 14 to 47 years. And sports included NBA, NFL, MLB, NHL, as well as various other elite athletes, as well as amateur athletes in a variety of sports. So this was the breakdown from the Downs and Blacks scale. You can see this just highlights how all of the studies, we had 5 that were moderate quality with the other 9 remaining being low quality. And this is a breakdown of the different studies. And you can see that the majority of the studies had either a microdiscectomy, open or tubular laminectomy and discectomy. And then there was a couple that there was one study that did nucleotomies and discectomies, and as well as percutaneous discectomies. And I did want to point out that these were all retrospective cohorts as well. So when they broke down the numbers, 739 athletes were treated surgically. When they looked at surgery versus conservative treatment, 84% of patients that had surgery returned to sport, and 76% of patients that had conservative treatment returned to sport, and overall showed no statistical significance. When they looked at the return to sport at a similar level after surgery, 3 studies specifically looked at that. One study had 38%, other study had 63%, and one had 65% with pooled data looking at being 59% of people were able to return to sport at similar levels. But they did not report any return to level of play after conservative management. Time to return to sport was reported in 8 out of 14 studies. The surgical group required more time to return to sport than the conservative treatment group, and they noted a recurrence rate of herniation between 9 and 31% in the studies. So they also looked at career longevity. In patients undergoing surgery, patients that played baseball had shorter careers after surgical intervention, where patients in the NFL had longer careers after surgical intervention. And they noted that NFL players had longer careers, played more games, and were younger than the conservative group when they looked at the 2 cohorts. And this varied by position, with the more, quote, skilled positions having longer careers. In 36% of athletes, they did note that they had premature retirement that was looked at in 5 out of the 14 studies. When they looked at recovery time, professional athletes had recovery between 5.2 and 8.7 months, where non-professional athletes had recovery between 7.5 weeks and 6 months. And this was related to the requirements of professional athletes are so much more than a non-professional athlete. So it takes them a little longer to get back to their starting position. Limitations, I think this study does point out some very significant limitations when looking at the long-term outcomes of disc herniations. Most of the studies that they looked at were low quality evidence. All were retrospective cohort studies. There was a wide variability in reported outcomes. They broke it down to like how many bases were stolen, the batting average of patients versus different football and NBA and basketball statistics. And I think one of the biggest things is this wasn't a heterogeneous patient population at all. Their age range was from 14 to 48 years old. And I just don't know how you can compare those different populations and have pooled data like that. And the majority of the study population was male, so this wouldn't be very applicable to our female athletes. So in conclusion, return to sport after lumbar disc herniation showed no statistical significant difference between the surgical and non-surgical groups. This study showed the ability to return an athlete to the same level of sport after disc herniation is variable and may be overstated, and highlights the need for prospective high quality studies. I also think that this article also highlights, I've seen it published a couple times, kind of the criticism of systematic reviews at this time point. I think they're viewed, at least in the academic setting, as just coming from residency and being a fellow is an easier setup. You don't have to go through an IRB process, et cetera. So I think we have to be careful looking at the systematic reviews that are coming out to make sure that the quality of evidence is good and that people are following the appropriate guidelines to do these studies. But I think it also is beneficial to see these studies as well to show what work needs to be done in the literature to move forward with being able to provide patients with good information.
Clay, that was great. And I think the reason we wanted this article was to open up a discussion and ask everyone here as faculty specifically, how long do you restrict these patients? And when do you let them return to even recreational sports? I mean, in Colorado, like a lot of places, we see a lot of skiers, and I tend to let them go back at 6 weeks, but I can't say it's based on science. But I would be interested to see what people think when they've removed the disc, they know that there's a hole in the annulus before they really allow them to go back to recreational and or professional sports.
This is an inspired choice of a paper that you put in there, because the dynamic with athletes, whether they're pro or amateur NCAA level, is completely different from that of the regular population that we, for instance, see in the sport trial, meaning agents, contracts, or eligibility status for amateur athletes puts a high time pressure on. These are super fit people, and they want to get back here and now. They usually don't want to take the 3 or 6 months or longer rehab, like for an ACL or so. They want to get back here and now. So this is a very valuable insight because, again, these are high-pressure people. They have short eligibility or contract terms and need to return to function. So the dynamic in this paper, and this is my question for Jacob, is how did age of the patients factor in as an odds ratio in this paper?
You're muted, Jacob.
You mean Clay? Clay presented the paper.
Sorry, Clay.
Yeah.
I honestly, I would have to look that up. I don't remember that off the top of my head.
Hey, Jens, I can answer that question in a partial patient population. So many years ago when I was on the medical staff for the Dallas Mavericks, I was kind of asked to look into the NBA database on exactly this, prognostic factors of lumbar disc herniations. And we found only one prognostic factor, age. If the patients, the NBA players had a lumbar discectomy prior to age 30, they had a 100% return to play. Over age 30, a 100% risk of retiring because of their back. So, and that's the only specific population I know. I'd also like to make a comment to Clay, because you made a very good point about systematic reviews, and And I've got a little bit of knowledge because I got kind of put up to be a deputy editor of the European Spine Journal, and being the low man on the totem pole, I'm in charge of systematic reviews. And I've learned a whole lot about them, and we get probably 8 to 10 a week because it's easy research. It can be done by a grad assistant, et cetera, anybody in your department, and it's an easy publication. And you pointed out the weakness of this particular systematic review. And the other thing, on the other hand, is systematic reviews have high impact factors. So journals like them, but they also need to be taken with a grain of salt. So that's an excellent analysis.
Yeah, and that's, with my early knowledge and learning the literature, when you're taught in medical school, they talk about the high impact factor of systematic reviews, and you tend to look at those. But as you start to understand the literature a little bit better, you can see some of the systematic reviews don't all carry the same weight and same punch.
Absolutely.
Mike, you asked an interesting question when we let him go back. I think we all, have adopted that 6-week rule. We start them in rehab, 2 weeks after surgery, and work on their core and, let it rip. But you're right. I mean, there's a hole in the agnes. It's not healed. That, there is a significant chance for a herniation, but I don't know that we have another alternative.
Yeah, Mike, I tell my patients the same thing, 6 weeks, but my pro athletes, I send them back to their we'll rehab them for 6 weeks, and then I'll say, you can start training, but you're probably not getting back at an elite level for 3 months.
That's a good point. Good.
Mike, you, Clay, and Jacob did a great job on a topic that you'd think would be mundane, but it fostered a lot of great conversation. I have a 20-second anecdote and then a quick poll. About 6 years ago on a Friday night, I got an email with an MRI showing a huge posterolateral herniation and a note that said, "Call me." And this was a professor of neurosurgery at a very prestigious institution at one of our big cities. And I said, "What's up?" And he said, "That's me." And he said, "I got terrible sciatica." I said, "How long is it going on?" He said, "I woke up with it this morning. What would you do?" So I said, "You know the drill." I said, "Get a selective nerve block tomorrow, get another one in 10 days and see if you can ride it out." I said, what are you going to do? He says, "I'm having surgery 7 o'clock tomorrow morning." So my question is, from a spine surgeon standpoint, if you had a large disc herniation and pretty severe sciatica, what would you do? Early or late, Mike?
I'd take it out right away so I can go back to work. I'm not going to take the 2 weeks off. I would probably, if I had a large extruded fragment in my hands, I would take it out. And that happened to my wife last summer. And as soon as she told me she had that, I took it out. And I believe I would do the same.
Rick?
But I don't give all my patients the pain.
I would give myself a week or two.
Scott?
Medrol dose pack, week or two.
You just want the euphoria from the Medrol dose pack.
Hey, listen, Mike, in Dallas or in Texas, we're tough. We would still work despite the bad sciatica.
How about Mike Heisey?
Well, I just did it. So
Right.
It's only been about 3 months for me. But I did have the injection. I did have some PT before. So, but not 6 weeks, though.
Jens, are you still on the mic?
Yes. Just looking at a case here right now. We got a lot of action. If I have a motor deficit and severe pain, I'm having the freaking disc out, period.
No, what if you don't have the motor deficit, just sciatica?
What's a little pain?
That's right. You trained in Texas, so that's why.
I don't know. We have our secret weapon is Peter Derman. Peter just took out a 3.5-inch piece of extruded disc at L23 on a patient of mine yesterday through a foraminal endoscope. So with that, I would go for something early too. Maybe the next morning. Hey, thank you very much, Mike. You guys did a great job. We'll see everybody next week.
Okay,
great topic.
Take care. Have a good weekend.
I remind everybody that tomorrow is a full moon at Halloween, and that won't occur for another 19 years. Many of us will be retired.
Wow.
So enjoy them.
Okay.
Good to
Don't
know.
get sick eating too much candy.
Yeah.
So.
Thanks, Mike.
Thank you.
Thanks for watching. Hit the subscribe button for more medical content.